The problem of IOL measurement in ectatic corneas, as we all know now that keratoconus is a progressive disease, and we have a lot of patients with keratoconus, and these patients are getting older, and we treated them, and now they have cataracts. So what should we do for the surgical management of cataract in patients with keratoconus? We have to put 3 pillars in our mind: their age, the stability of the cornea, and the stage of keratoconus in this patient. So the main problem is how to calculate the intraocular lens and refractive outcomes in these ectatic patients, especially these patients are of high demands. First, is the cornea stable or not? This depends on the age. If the patient is less than 30 years of age, we should cross-link the patient before doing any surgery for him. And if he's more than 30 years, we can follow him up. If it is stable, we can proceed for the cataract. If it is progressive, we should cross-link him and then to do the cataract. So stability of the cornea is a must to take the good measurements. As we all know, the signs of progression is thinning of the cornea, increase of the curvature. The difference between the superior and inferior meridia is 1.5 diopters. And the second question, after being stable or not, is it regular or not regular? And in another word, can we depend on the K readings for the accurate biometry or not? How to make the cornea regular before cataract surgery? Of course, doing pentacam and all the preoperative investigative measures. And if you have the facility of intracorneal ring segment implantation, this will be the best to do it with the cross-linking if there is progressive ectasia. And we should wait at least for 3 months after implantation of the ICRs to take the measures. So after corneal stability and regularity, we have 5 scenarios. First, mild irregular cornea up to 52 diopters. Second is moderately irregular cornea. Third, if the ICRs are not applicable. Fourth, if we have an advanced keratoconus. And the fifth is if the patient has post-PKP cataract. With mild irregular cornea with case up to 50 diopters, we should do preoperative all the measures needed with pentacam, optical K readings, to use the third and the fourth formulae. And now we were saying in the old days, not the old days, since about 2 or 3 years, we depend on the Haig's L, but now definitely the Barrett standard universal 2 is one of the best to have the best IOL measurement for these cases. And again, all the results should be within 2 diopters of the Haig's L formula. This is an example of a patient who had advanced keratoconus in one eye, and the other eye we did cross-linking, so we did rings and cross-linking for him. And of course, there's a marked improvement after the rings, and we depend on this case to do the cataract. Astonishingly, after cross-linking, the cataract is a little bit hard. This is a 35-year-old male who had cross-linking. He was -11 before the cross-linking, and it seemed that the riboflavin had been introduced in the AC, and the lens had been stiffened. So when you do the cataract, it's nearly mature, hard cataract. So in spite of being young age, but it needs a lot of energy and power, as you're going to see now, doing the chopping technique. So be careful from the history of the patient had previous cross-linking. You are doing cataract for him expectantly. As you see here, the cataract is very hard and it needs a lot of power and chopping techniques. Again, if you have moderately irregular cornea with the Kmax between 52 and 62, you have to stabilize the cornea by the rings. And again, doing cataract with the presence of the rings is not a big deal. It doesn't need tips or tricks. You can do it easily. You can see the rexes. Even you can be guided with the rings to have a good rexes, and you can do your cataract so simple. This is the same case one day after the surgery. This is another case after intakes long ago, and had infection. One of the intakes had been removed, and then she developed cataract. She's glaucomatous. As you see here, the visualization is a little bit difficult, so be careful while doing these cases. You need a lot of time because you cannot see well the posterior capsule. The third scenario, if you don't have the ICRs, if you have advanced cataract, can depend on the subjective refraction for these ICRs, or you cannot afford for the ICR, or it's not present at all. So make the surgery on 2 steps. And this is a message which is very important. If you have advanced keratoconus, you can tell the patient, I'm going to do for you first the cataract without putting an IOL, and then after removal of the cataract, reassess the vision and to see whether you're going to deal with the cornea or to implant an IOL. Because in these cases, you have the biometry with -17 and -15 diopter of IOL, which is actually not present, and it is not a true biometry. So don't depend on an irregular cornea. And after being the patient being aphakic, you can do subjective refraction. and you can put hard contact lens and to assess the IOL needed after the surgery. So regulation of the cornea is very important in these cases, and to put the second IOL in the back of the sinus. Toric IOLs, for me, I do not like putting toric IOLs for the advanced cases of irregular cornea, but it is still debatable. You have a very regular cornea with a small amount of residual astigmatism, you can put the IOL, the toric IOL. So these IOLs only in selected patients with stable mild to moderate KC with good vision or without corneal scars, of course. The fourth scenario, if you have advanced keratoconus and the pachymetry is less than 400 with more than 62 diopters, you cannot depend on this K to do the biometry. So you can do the triple procedure with DALC, phaco, and IOL. If you have hydrops, you can depend on the K readings of the other eye to put it and to take it as a measurement for this IOL. This is a patient who had, after acanthamoeba keratitis scar, for her DALC, and after a year she developed cataract surgery, and take care to not to keep the endothelium as much as you can safe by putting a lot of visco, using the Archinov technique of soft shell technique, and have a good specular microscopy and follow up. And this is the patient after 1 day. So to conclude, counseling and complete explanation to the patient is a must, adequate preoperative investigations, all plans and tools to protect, stabilize, and regulate the cornea, the least ultrasonic power, and enough time for the compromised cornea to heal. Summarize, stabilize the cornea, regulate it, may postpone the IOL in advanced cases, always target low myopia, which can be solved, never ever hyperops. Advanced cases do the triple procedure, and the toric IOLs is debatable. Thank you so much.